But right now I'd like to move on to our last speaker, who will give a brief talk on COVID-19 and endemic fungi. This is George Thompson, GR. He's a professor of medicine at UC Davis in the Division of Infectious Diseases and also the fellowship director. I think his emphasis will probably be mostly on cocci and COVID association, and perhaps touch on other areas where it is relevant. GR, thanks for being here.
Yeah, great. Thanks so much. Can you all hear me okay?
Yep, and see your slides.
Well, great. So thanks again to the organizing committee. It's really a pleasure to be here and talk about COVID-19 and the endemic mycoses, and really some of the issues that have come up for us during the sort of the dual pandemics that are ongoing, at least for us that see a lot of cocci. So the key questions for us really to talk about, just to kind of go through these, COVID-19 and the association with endemic mycoses, that was really a nice introduction about Cryptococcus in the prior talk. And this is going to be fairly similar, but with a few little wrinkles that really come up in the care for us. There's clearly overlapping risk factors for both diseases, both COVID-19 and particularly coccidiomycosis, which we'll get into in a few slides. And the overlapping clinical presentations, particularly for mild or moderate COVID, that's really a diagnostic dilemma for us, at least for the first day while they're in the hospital. Unique risks for relapse will really be the focus of this talk. There's clearly transient immunologic defects associated with COVID-19. You know, we see Aspergillus cases, we see mucormycosis cases, so we'll get into that just a bit. And then what impact do the treatments we're giving our COVID-19 patients have on coccidiomycosis or even relapse of disease? A little bit on some stuff we've been doing in the lab with diagnosis and monitoring and metabolomic signatures. And then how do we really counsel and what recommendations do we have for our patients? So real briefly, just I think we all know the life cycle of these different endemic mycoses, and we're really just going to focus on the first three: Histoplasma, blastomyces, and coccidiomycosis. So these are all environmental molds. They're in the soil. They require exposure, of course, for infection. So whether that's Histoplasma, arthroconidia from coccidioides, or blastomyces, these require inhalation in the lung. They either cause pneumonia or really no symptoms for the vast majority of patients exposed, but they do unfortunately disseminate for some of these patients, and then at that time encounter the healthcare system. So this is a little bit US focused talk, since these fungi primarily within the United States, and a few I saw Elon's on here, so blastomyces certainly in Canada as well. But this will be a little bit US centric just because coccidiomycosis, most of the cases really are in California and Arizona. So the overlapping risk factors with COVID, you can see here, really the groups that primarily are at risk for both either coccidiomycosis or COVID-19 are largely occupational, so construction workers and largely agricultural practices. And you can see here why a soil-dwelling organism would be very difficult to avoid within the agricultural environment. These spores are actually thrown several miles frequently during agricultural processes. And then we've really dealt with the wildfires here in California the last few years, and we actually think those are responsible for throwing these organisms up potentially into the jet stream and then blowing these different spores really throughout the country. There's been some cases of coccidioides as far to the east as Missouri, where it's not endemic. So how it got there is still a little bit of a question mark. The incarcerated populations really have a very difficult time with both of these infections. There's been lots of outbreaks of COVID-19 within the California prison system. A lot of the prisons are within the Central Valley, where most of the coccidioides cases are seen. There's very dry land in that area, certainly. So with any wind, it's going to cause these spores to become airborne. So outbreaks of both COVID-19 and coccidiomycosis are seen within the California prison system. And then race, certainly with disparities, I think that's been really well presented in a number of recent publications, the risks certainly for COVID-19 in different populations. And then our Filipino and African-American patients really do have a heightened risk of severe coccidiomycosis for genetic reasons that Steve Holland and Amy Sue have really identified in conjunction with others. And then dust exposure. So particulate matter that's of 2.5 micron or 10 micron size really leads to both respiratory viral infections such as COVID and coccidiomycosis. And it's a little unclear if these different viral or fungal pathogens ride on this particulate matter, or if the particulate matter causes epithelial injury within the lung that later predisposes to infection. But you can see these really are overlapping risk factors for coccidiomycosis and COVID-19. that do cause some problems for our patients, certainly. So not only overlapping risk factors, but they do often have a similar clinical presentation. So if you presented one of these patients on rounds that came into the ER with upper respiratory symptoms, a dry cough, myalgias or arthralgias, a headache, fever, rash, and malaise, right now, we would have a little bit of a tough time without any other information knowing is that COVID-19, is that coccidioidomycosis, and the chest x-ray really is not going to tell the difference either. You can see this lower left infiltrate here. And it really depends on the pretest probability of COVID-19 or coccidioidomycosis. And where we practice, between 17 and 24% of all community-acquired pneumonia is actually due to coccidioidomycosis in the Central Valley. So it's truly endemic. So to overlay that with a pandemic of COVID-19, there's really going to be a lot of patients that could have one or the other or potentially both. And that's really what we have been dealing with is patients who've had prior cocci and then coming with COVID. That's been a big complication, we think. So there's clearly been sociologic factors that have impacted certainly the epidemic aspect of coccidioidomycosis that we have dealt with. The stay-at-home order, masking. These are not N95 masks that most of the people in the community are using, but what about cloth masks, surgical masks? What's the impact that's had on coccidioidomycosis incidence? And then certainly less travel, less enjoyment of hobbies, all these things may decrease exposure to coccidioidomycosis as well. And then here's really some early data from the California Department of Health. This is not on their website quite yet, but it includes both California and Arizona cases. And you can see here, if you look just at California, which is blue, really since 2001, you can see our numbers actually are slightly down from 2019. And this is really thought to be from some of those sociologic factors. So less travel, less large-scale exposure. The use of masks probably played some role in reducing the number of coccidioidomycosis cases. But Arizona, you can see, continued to increase from 2019. So that's really pretty interesting. Despite this small number, this is maybe 20,000 cases that have been reported for 2020. You have to remember, reported cases are a small minority of actual total cases. A lot of patients with coccidioidomycosis will not ever have a formal diagnosis. They'll cough or not feel well for several weeks, and the disease for the vast majority of people is going to self-resolve. And so that's what you see. So the true number of cases, it's thought to be about 150,000 cases a year. The CDC has an ongoing effort right now to update that number with several different modeling parameters. So if you take this 150,000 people and maybe we'll multiply it by 2 years for 2020 and 2021, have 300,000 people, and somewhere between 10 and 20% of those patients are going to have COVID, naturally acquired infection. That's a lot of patients that have had both coccidioidomycosis and COVID-19. So one of the problems we run into is, just to back up just a little bit, so this would be just for coccidioidomycosis, but certainly happens in histoplasma, in blastomyces, and even in cryptococcus, is as this pneumonia sort of heals, it can form a coin lesion or a nodule. And that's certainly seen on CAT scan here. So there's a peripheral nodule here. This is benign. This is old fungal disease that's been walled off. It's very similar to tuberculosis with granuloma formation. But it causes a lot of problems during clinical care. Is this lung cancer? Is this old endemic mycoses? And really to zoom in just a little bit on that and to borrow from our colleagues in tuberculosis, when these patients form a granuloma, this is an active process, of course, right? So there's local infection at the site, release of pro-inflammatory mediators, and you have a resolved granuloma. But really how we view a resolved granuloma, I think has been a little bit, at least was taught to me wrongly. And this is a really nice paper by the group out of University of Washington that used a replication clock to look at plasmid loss over time in tuberculosis to actually see how much of this organism in a granuloma continues to replicate. Because I think wrongly we have thought tuberculosis and certainly fungal pathogens in a granuloma are inert or completely quiescent and there's no turnover, and that's not really correct. So we know that they turn over time. And with that, you have continued antigen exposure to sort of the granuloma cell wall. So with any loss of immunologic control, either through loss of CD4 cells, interferon gamma, TNF alpha, a granuloma can easily rupture and the infection recur. And that's really the big risk that we have seen with these coccidioidomycosis patients. They've got well-formed granulomas over their body for a number of years. And with a hit to their immune system, the granulomas can sort of open back up and the infection relapse. So this low-grade replication, again, we do think causes repeated antigenic exposure. For our coccidioidomycosis patients, we've seen that even pre-COVID, where we think their granulomas rupture and they get sort of a serologic relapse before ultimate recontrol of the disease. But during COVID, we do think this is a potential hit on their immune system that can lead to relapse of their coccidioidomycosis. So we do know that these granulomas are active when they're resected. They're often culture positive, so it is active in live coccidioides. So what's the total number of patients at risk? So I mentioned, so about 150,000 people a year are infected, but what's the cumulative population for those who have had cocci at some point in their life? And this is really difficult to discern. So there had previously been a skin test for coccidioides, and these are older studies, obviously 1930s and then 1983, not quite as old, but found rates of positive skin tests within the endemic region with tremendous variability. So between 4 and 10% in Kern County, California, which is where Bakersfield is, and then Maricopa County, which is Phoenix, 21%. And you can see from these different studies in some of the modeling that they've done, if you've lived in the area for 50 years, one of these studies thought you've had about 100% chance of prior cocci. Some of the others quite a bit lower, between 40 and 70%. And we really can't replicate these studies now. So the current skin test reagent is spherusol, which is made a little different than the prior skin testing reagents. It looks like it's probably not as sensitive, misses some of the patients who've known to have cocci. But in the 37,000 prisoners who were tested within the California prison system, the rate of positivity for them was about 8%. So that's still a tremendous number of people within California and Arizona that have had coccidioidomycosis at some point in their life, whether they were formally diagnosed or not. So where are these different locations? So you can see Kern County, which is located down here, really makes up the brunt of the cases of coccidioidomycosis, followed by several of the others within the southern San Joaquin Valley region. And I've overlaid this here with the number of COVID-19 cases they have per 100,000, because these 3 different counties with the highest rates really also have some of the highest rates of COVID-19 that we've seen in California. And some folks out of UC Berkeley actually put together this sort of graphical analysis here to graph COVID-19 cases compared to cocci cases. So you can see Kern County here at the top, and then some of these are Indian reservations within Arizona, and then also Kings County, California here. So really these overlapping epidemics of COVID-19 and coccidioidomycosis have put a lot of people within these different regions at risk. So what do I mean by risk? So I think that, certainly in Tom Patterson's talked about the different risk factors and immunosuppressive effects of COVID-19. The therapy we give for COVID-19 is highly immunosuppressive corticosteroids or other immunomodulatory agents. They do develop leukopenia and lymphopenia, immune dysregulation, which I think is a bit of a wastebasket term, structural lung disease from the fibrosis with COVID-19, and then prior antibiotics may change the microbiome just a little bit. But if you really dig through some of these different immunology papers, they do have a decline in their CD4 count. And actually this Frontiers paper here graphed what they think is the decrease in the CD4 count over time with mild COVID here, and compared it to acute HIV infection. So you can see they do have a precipitous drop in their CD4 count from normal to maybe in the 600s. And then with severe COVID, like we see in our ICU patients, it can be quite low, as you see here. So I thought this was really a pretty interesting paper. The reasons for that are a little bit unclear, at least to me. The authors of those different papers have speculated that COVID-19 directly infects lymphocytes. Also, certainly with any sepsis or immune response, you're going to get T-cell exhaustion, apoptosis, and certainly decreased production of different CD4 and CD8 cells. So I think together this may potentially delineate the major risk factor for recurrence of endemic mycoses following COVID-19. I think that this loss of CD4 cells is sort of what leads to loss of control of those different granulomas that we have seen. So to study this, we've really tried to pull all of our patients who've had a known diagnosis of coccidioidomycosis and a known diagnosis of COVID-19. And obviously that's going to miss a lot of people who were either never diagnosed or have been lost to follow-up. But this was really just a case control study to look at those who had coccidioidomycosis and relapsed after COVID-19 versus those who did not relapse over COVID-19. And really, we didn't find any difference between groups at all, except for the time of their initial diagnosis of coccidioidomycosis. So if they had a recent diagnosis of coccidioidomycosis, they were much more likely to relapse after COVID-19 than those who had cocci in the distant past. So the differences in time there were 9.3 months in those who relapsed versus 27.7 months in those who did not relapse. This is very limited. We've had a fairly low number of patients that had truly diagnosed relapse disease. Again, I think we've missed a lot of these. No differences in age, comorbidities, receipt of antifungal therapy. But really, this is a group that has not had a lot of comorbidities, at least when we look through their charts. Diagnosis of cocci was quite recent for most of these, all within 2-year time frame. All of these were off antifungal therapy at the time of relapse. A lot of these did have a bit of residual disease, which a cavity or nodule, when imaged at the end of their antifungal therapy. And they all had a serologic increase in addition to their symptoms, all treated and all had clinical resolution. Well, so one of the problems with this is when we've taken blood samples from all of these patients, from some metabolomics work that we've done, and we've been focused on this for a couple of years, actually, even pre-COVID-19, and found that really the metabolomics were helpful diagnostically to differentiate patients with a respiratory infection from a non-cocci illness versus cocci or valley fever. You can see the metabolomics profiles are clearly able to delineate healthy patients with other etiologies of their respiratory illness versus coccidioidomycosis. So then we took this group that had coccidioidomycosis to see if the metabolomics could also stratify them by meningitis, which is sort of this red oval, versus non-meningitis, which is this orange sort of oval. There's just a bit of overlap, certainly, but you can see here they're clearly different groups by metabolomic data. Well, from this, that's sort of helpful. We can tease apart maybe even who's going to disseminate and develop meningitis. But we took this group of patients that had meningitis or disseminated coccidioidomycosis, which is this red column here, and then this blue column is basically those who did not disseminate. And then we took our patients who had a history of cocci and had relapsed following COVID, and you can see their metabolomic profile actually switched to the same as those with disseminated disease. And that's different than patients who had COVID alone and no history of cocci. So I can't show you all the data. My collaborators weren't real crazy about that, but this is in press. But you can see it really switches a lot of the immune markers of the metabolomic profile to more of a disseminated picture. So we do think that probably most of these patients are going to need antifungal therapy while your immune response returns to normal. This is going to need a lot more follow-up work. We're fairly excited about this. One of them is actually a novel immunologic pathway that we think may actually be provoked by COVID-19. So this may really predispose a lot of these patients to symptomatic relapse and hopefully not dissemination, but that really has been seen in one of these patients that was published in Military Medicine, which was an accelerated progression of disseminated cocci following COVID-19. So this was published by the US Navy. This is a 23-year-old African-American male, had mild COVID while aboard the USS Theodore Roosevelt. That was a well-described outbreak early in the epidemic. And this patient did not have any specific medical care for his COVID-19. He did very well with just symptomatic treatment. But 30 days after COVID-19, he developed fever, chills, and night sweats, had new skin lesions. And you can see here a PET CT showed spinal lesions as well, developed generalized lymphadenopathy and lung lesions, was ultimately diagnosed with coccidioidomycosis on a biopsy. So a 30-day time frame to go from asymptomatic to skin lesions and disseminated cocci is very rapid for those of you who don't see a lot of coccidioidomycosis. So I think that does take a bit of speculation to see that COVID-19 pushed the disease that quickly, but I think in line with some of the metabolomics data that we have seen, it makes a lot of sense pathophysiologically as well. So that's kind of the end of the story for cocci, and I'm very biased. That's what we see the most of here. But to look through the literature for the other endemic mycoses, there's really not much that's been reported. There's been, I think, 6 cases of histo now. There's been 4 cases here that we're going to talk about. These all had HIV, had active histoplasmosis. COVID-19 was incidentally found in these patients. It really didn't appear to impact their treatment of histoplasma at all. These patients were already on antifungal therapy for histoplasma, though, so I think that likely played a significant role in decreasing any of the potential morbidity from concurrent infection. And then I'm only able to find 1 reported case of blastomyces in association with COVID-19. And this patient had severe COVID-19 postpartum, required ECMO. They really didn't turn around quite in the fashion that the treating physicians thought that they should. They actually found reactivation of blastomyces in this patient. The treatment was not delineated. This is a poster presentation at CHEST, and the patient did survive to a skilled nursing facility at discharge, but really not a lot of details provided. not able to find any reports about sporothrix, emergomyces, taloromyces, or paracoccidioides, looking through literature. So I think we would be very interested in how those patients have done with concurrent COVID-19. I think that would really help us fill in some of the details in this story, but we just don't have any of the data for that quite yet. So in conclusion, for some of these patients with COVID-19 or cocci, certainly within an endemic region, overlapping risk factors are really going to be difficult to sort through early in their presentation. They do have similar clinical symptoms at times. We do think that COVID-19 induced immunosuppression leads to relapse of infection from these granulomas. Novel pathways really may heighten their risk for this, and really a high index of suspicion is required for diagnosis. And with that, I'll thank you so much for your attention and listening today. Thanks to Gail Cooksey for providing some of the data really ahead of time for the number of cocci cases in California and Arizona. And then thanks to our collaborators here for some of the metabolomics work. And then you can see here, this is what's called a haboob, sort of a windstorm where it picks up massive amounts of dust and then dumps them on cities throughout Arizona or the Central Valley in California, which is why so many of these patients develop coccidiomycosis. But with that, I'm certainly happy to answer any questions. And thanks again for your time.